This is in the vascular chapter, by the way, chapter 26. This is not under the respiratory section. Okay. We'll go back to the respiratory section later for acute respiratory failure. Now, pulmonary embolism is actually a vascular problem. Risk factors are the same as with thromboembolism and venous thromboembolism. Now, let's start with VTE first because, like I said, the risk factors are the same. Treatment is also very similar. Just depends on how bad the pulmonary embolism is. By bad, I'm talking about the one of three categories. One is low risk PE, one is submassive, and the third is massive PE. So what is VTE? So this is a blood clot in a vein, usually in the leg. It can also occur in the arm, as in the cases of PICC lines, for instance, okay? Or it could also occur in any other condition. But most likely, most VTEs occur in the lower extremities. If you look at the pathophysiology, there are three ways our body can form a blood clot. So let's review from MedSurg 1. This is known as Virchow triad. What is Virchow triad? One is venous stasis, the other is hypercoagulability, and then third is endothelial injury. I discuss all this in detail in the recording, so I won't do that now. But just know that these are the three ways our body makes a blood clot, meaning if one or more of these conditions are present, we will form a clot. I'll just give you one example. Endothelial damage is actual injury to a blood vessel. Does not matter whether that's an artery, a capillary, or a vein. When there's injury to a blood vessel, our body will do what? Form a clot to stop a bleeding. Make sense? Yeah. Okay. Another example is venous stasis. So you're sitting in the same position for 16 hours toward Cebu. You could form a clot because the blood does not go back to the heart. It stays too long for more than a few seconds in your legs. Or it could also be from cardiac, okay, atrial fibrillation, atrial flutter, same thing. Blood pools in one part of your body, this time in the atria. It can form a clot there too. Okay, so that's venous stasis. Third is altered coagulation, or also called hypercoagulability. Conditions such as cancer, conditions such as smoking, and if you're using oral contraceptive pills, for instance, or any other blood disorder that you may have, that's called hypercoagulability or altered coagulation. You form a blood clot. So again, since these are the three factors leading to a blood clot, can we also manipulate the same three factors to prevent one? Correct. So if you have venous stasis, so what do we do? Keep it moving. Okay, yeah, compress the legs with antithrombic pumps, yeah, stockings or compression devices, right? Or you can also, in the case of atrial flutter, we can't treat that easily, so we'll put you on anticoagulants. Okay. And then in the case of endothelial injury, so you experienced trauma, you had surgery, same thing. We can do both, either SCDs or put you on anticoagulants. And then the same thing for altered coagulation. We'll treat the underlying cause. If you have cancer, we'll treat that. We'll deal with the clots separately. All right? Yes, sir.
Can you substitute those anti-coagulants with aspirin?
No. Antiplatelets do not replace anticoagulants. They're two separate drugs. Antiplatelets do not prevent DVT or PE. They can't. Okay, because remember, there's two pathways to form a clot. There's the extrinsic and intrinsic pathway. So extrinsic is simply the platelets, okay? But we have intrinsic, which is forming the stable clot, okay? Meaning we're talking about clotting factors. So antiplatelets cannot alter clotting factors. So they're useless. Okay, so you can't just say, oh, just place you on aspirin to prevent DVT. Will that work? Not if you have one or more risk factors. Do we understand? Okay, so you can't say in report, let's say, oh, what's the DVT prophylaxis? Aspirin. You sound stupid. Okay, so it's not an anticoagulant. Are we clear? Okay, so what's the aspirin for? Is it to prevent DVT? What's that for? What we talked about that. So this semester we prevent a stroke or prevent a heart attack, right? Yeah. So if you have a CAD or stroke, then we put you on aspirin and Plavix or clopidogrel. Or also if you have, let's say, PAD, peripheral artery disease, same thing, right? And what else? Only aspirin, Plavix. We also gave statins, right? Yeah. Okay. All right. Very good, children. Okay, risk factors. Again, I already mentioned these are examples: endothelial damage, venous stasis, and altered coagulation. Long list. So I can put that on a select all that apply question. Signs and symptoms. Usually VTE is in one leg. So there's unilateral leg swelling. You're extremely unlucky if you get a blood clot in both legs. Okay, that's very, very rare. It's like being hit by lightning. Okay, so it's usually just unilateral leg swelling and pain. I mentioned PICC lines. Okay, so PICC lines are notorious for blood clots, so they can cause VTE as well. There's edema, pain. If the vein affected is superficial, you may see erythema. Okay, the leg may look red. Again, only for superficial DVTs. But if it's deep, then you won't see any redness, but you will see the swelling and pain. Are we still relying on Hohmann sign? No more. Okay, we've abandoned that because right now I have Hohmann sign. Okay, I've had this Hohmann sign for like 20 years now. Okay. How do we diagnose if you have a VTE? We have to see it. However, if the patient doesn't have any symptoms or the symptoms are vague, then we'll have to do blood work first. They won't diagnose, but they will help arrive at the diagnosis, particularly bleeding time and D-dimer. Okay, so D-dimer is an FDP or platelet degradation product. What is D-dimer again? You discussed these in your presentation last semester. Yeah, but what is D-dimer? What is that? How does it prove DIC or, or how does it help diagnose DIC or help diagnose a blood clot? This is what's left over of fibrin. Okay, so remember, in the clotting process, once a clot is formed, what is the next step? Now we have a clot. Let's say you cut yourself. Okay, so Christina cut herself. She, waited a few seconds, up to a few minutes. It finally stopped bleeding. That means there was a clot, correct? Stop the bleeding permanently. So now what? What will the body do with that clot? It'll start breaking it down slowly, okay, over several days. What's left behind when you destroy fibrin is D-dimer. Okay, so therefore, if the D-dimer is high, what's the only explanation? You made a lot of fibrin clots. So the higher the D-dimer, the more clots are being dissolved by the body. Okay. Prevention, we already talked about prevention. Management, again, depends. How bad is the VTE or how bad is the PE? For a DVT or VTE, typically this is only almost exclusively treated with anticoagulants. Which one? Doctor will decide, depending on the patient's risk factor. So our usual, very rare is it treated with surgery. Okay, very rare because blood clots aren't that big in order to warrant surgical removal. So our drugs are anticoagulants. So we can choose between direct thrombin inhibitors or factor Xa inhibitors. So we have a whole table for that, table 26-2. Let's go here. So doctor can use heparin. So if it's acute DVT or VTE and it's multiple, meaning the patient's risk is higher, they will be given heparin IV, continuous infusion. This will, of course, be temporary until the patients can be safely discharged on oral anticoagulant. Okay, so intravenous heparin is always short term. Okay, the purpose of giving it IV is we need immediate anticoagulation. We need to give it now. We need to start preventing more blood clots from forming. Speaking of which, what is the action of anticoagulants? Why are they used to prevent and treat VTE? What exactly is the action of an anticoagulant? They, you know, alteplase, right? Alteplase does what? Dissolves the clot. So what will an anticoagulant do?
Just to prevention.
Prevent new ones from forming. And what does it do? There's already a clot. Prevents that clot from progressing, meaning prevents it from getting bigger because a clot will get bigger and bigger. So anticoagulant prevents that. Why IV? Why not sub-Q? There's already a clot. Okay, so if we're trying to prevent one, we can give it subcutaneously. By the way, if we give heparin IV, the half-life is only 1 hour, maximum 90 minutes. If we give it sub-Q, the half-life becomes 8 to 12 hours. So you understand why, right? Why we give something sub-Q and why we give something IV. You understand? Why did we give it IV? We want it now. We want the protection. We want the anticoagulation now. Okay, so that's why we gave it IV. What's the purpose of giving it sub-Q? To prevent one. Okay, a subcutaneous heparin will not do anything if there's already an existing clot. Are we clear? All right. And what do we monitor with heparin? PTT every 6 hours. What's the antidote? Protamine sulfate. What are your responsibilities? Watch for. What else? There was a complication. You talked about this in your presentation last month. HIT. Don't forget. What is HIT? What is that?
When your body reacted.
Is it dangerous?
Yes.
It's an emergency, yeah? Okay. Yeah, because what's happening actually in HIT?
It's a reaction.
You're actually making clots. Okay, so that the heparin is causing clots to form. So what's the intervention? Stop the heparin and put the patient on another anticoagulant. Okay. So what exactly do we monitor? How do we know the patient might be developing HIT? Monitor platelet counts. So what will happen to the platelet after exposure to heparin? Decreases by what? How much did it drop by? Half. Okay, approximately half after exposure. So that occurs over 1 to 2 days after the first heparin. Although there's a type 1 and type 2. So type 2 might develop later. Okay, meaning you had heparin today, it won't show until, yeah, or next month. Okay. Low molecular weight heparin, obviously this is for low risk PE, meaning it's not very concerning. I mean, yeah, PE or DVT, meaning you have a DVT, you have a PE, but
Not high risk.
Yeah, it's not high risk, meaning you have it's not affecting your hemodynamics. Okay, you're otherwise okay. So low molecular weight heparin, these are examples. And it's still heparin, so still watch for HIT. Half-life is 12 hours. Warfarin is only for who? When do we give, or to whom do we give vitamin K antagonist? Which is warfarin. Valvular problems. Okay, so clots caused by a valve problem. Okay. So we don't throw this thing left and right. So what's the most popular? The 10A inhibitors, okay, or direct thrombin inhibitors, right here. So our 10A inhibitors, although we have fondaparinux here, but this is still sub-Q. Okay, fondaparinux is, I believe, I can't remember the brand name, but yeah, this is sub-Q. The more popular 10A inhibitors are, of course, the oral ones. Okay. Top of the list is apixaban. At least in New York, you'll see apixaban on most patients who are on anticoagulants. So these include our AFib patients, A-flutter patients, history of a PE patients. Okay. So who will be given warfarin again? Okay, only those clots related to a valve problem. Okay. What's the antidote for warfarin?
Vitamin K.
Generic name?
Well,
Vitamin K won't appear on the exam because it's all generic name. Elise, you remember?
coffee. Oh, plus that or something. It's there.
Okay, let me know later. What's the antidote for these? It's heparin. There's none except one. Dabigatran, right here. This is the only one that has an antidote right here. Idarucizumab.
What?
Idarucizumab.
Oh, I see.
Okay. That's the only one. That's the only one that has an antidote. All the rest do not. Our only choice here, if you do have bleeding from these, of course, we stop it, right? Best thing we can do is give you plasma. That's the only thing I know that could help. Fresh frozen plasma. Yes, they're very convenient. These drugs don't require PTT, INR monitoring, nothing like that. Not like warfarin, not like heparin. But they also don't have no antidote. Now, for rivaroxaban or Xarelto, it does have one here, andexanet alpha or activated charcoal, but it's not really an effective antidote. Right? I mean, we can try, but these drugs don't really have a natural antidote. Make sense? Okay. So high risk for bleeding. In fact, I've only seen this in the textbook. In practice, we had so many patients that overdose. We typically just monitor for bleeding. And if they are bleeding, we give them plasma. Well, I've never given this drug or activated charcoal to reverse the effects. They don't order. And of course, you know alteplase, right? Okay. And here's your teaching for all patients taking anticoagulants. Any questions? Okay, let's go now to PE. So same risk factors, same Virchow triad, endothelial injury, venous stasis, hypercoagulability. This time though, the clot is not in the leg. It may start in the leg, but then it moved, right? It moved and then now it ended in your pulmonary artery, not really in the lung. So pulmonary artery. Now, if you recall, this is a clot in the artery, correct? In the pulmonary artery. Now, what do we call this? Pulmonary embolism. What did we call the clot that ended up in a cerebral artery?
No, thrombus.
What did we call that condition? A stroke.
Well, the stroke, yeah.
What did we call when there is a clot in one or more coronary arteries? An MI. So cerebral infarction, myocardial infarction. Why is this not called pulmonary infarction? It's a clot in an artery. Why? Why isn't it an infarction? Why didn't the lung die? The heart muscle died when there was a clot in the coronary artery. Brain cells died when there was a clot in a carotid or cerebral artery. Why didn't the lung tissue die here in pulmonary embolism?
Jesus.
No, it's in the artery. It tells you here, pathophysiology, it's a clot in one or more branches of the pulmonary artery. Here, you can have multiple small emboli and large in the terminal pulmonary arterioles. It's in the blood vessel. Why isn't this called pulmonary infarction? Why didn't the lung tissue die? Do pulmonary arteries perfuse lung tissue?
No.
In fact, what type of blood travels through the pulmonary artery? Oxygenated or deoxygenated? Deoxygenated. So therefore, are the pulmonary arteries perfusing lung tissue?
No.
It does not. So how does the lungs get their blood supply? Bronchial arteries. All right. So what do we call this condition again? Pulmonary embolism. So this will simply affect the heart and of course gas exchange. Okay. Of course the lung will die because you'll die. So of course the lung will die, but it does not die first. Does that make sense? Okay. You'll die first. And then the lung will die. Okay, so same again, exact same pathophysiology as with VTE. We won't repeat that. There is an infarction, but the clot must be in the bronchial artery, not in the pulmonary artery. Do pulmonary infarctions occur? Very rarely. Yes, they do, but like it's almost never happens. Okay. All right, clinical manifestations. Nothing specific. It's not really specific to a PE. They resemble a heart attack. They resemble heart failure. So all we can do is test for everything. So we'll draw the same things. We'll draw D-dimer. We'll draw BNP. What is BNP for? Heart failure. Okay. We get all that blood tests and then we send them for a scan, correct? We want to see, is this heart failure? We'll get an X-ray. We'll get a CAT scan. If it's PE though, the test is CT angio, so it always uses a dye. So what would be a contraindication for this test? Okay, so if the patient has any kidney injury shown on chemistry, we can't do CT angio. We will do instead a VQ scan. A VQ scan is also called a ventilation perfusion scan. But they use Q because it's ventilation quotient. Well, anyway, what is a VQ scan? This is a radioactive gas, meaning this is an alternative to CT angio, right? So we can't push a dye into the patient's vein. So what we'll do is give them a radioactive gas instead. So they'll inhale a gas with radioactive material in there, take a picture, and it will show which parts of the lung did not show the dye. There's the clot. Okay, because that's where the radioactive gas did not perfuse. So there's an obstruction there. Make sense? Meaning it would have been easier if we gave a dye, we take a scan, obviously we'll see you literally see the clot because that's where the dye will stop. Okay, dye stops there, it illuminates the clot or clots. Since we can't do that if the patient has any kidney injury, then we'll have to do the gas instead. Okay. Obviously, the CT angio is cheaper compared to the nuclear medicine VQ scan. But of course, blood tests, the D-dimer will help. But again, will the D-dimer diagnose the PE? It can. It'll just show evidence that, yeah, there is a clot. So just like a VTE, wherein we did the Doppler, correct? We did a venous Doppler. We had to locate, oh, there you are. Okay, we saw it on ultrasound. Same thing here. PE, we have to see it. Management, again, depends. What are the three categories of a PE? Low risk, submassive, and massive PE. Low risk patient almost has no symptoms at all. The only symptom for a low risk PE probably is a sense of impending doom, meaning they feel anxious. Hey, something's wrong. I can't say what it is, but I don't feel well. Then they take a scan. Oh, sir, you have a PE. Okay, so we'll send you home on this. Right, so we'll give them an anticoagulant, either low molecular weight heparin injections, and then come back in 6 weeks, right, for follow up. For submassive PE, we will give them anticoagulants and inpatient. Okay, so remember in VTE, we give them what first? So to give them immediate heparin what? IV. Okay, so if it's submassive, heparin IV. Low risk, low molecular weight heparin, or even apixaban, and then send them home. Submassive PE, they have to stay in the hospital. Okay, we have to observe them because they may have some heart problems as a result, meaning the PE might cause pulmonary hypertension and cause heart failure. Okay, acute heart failure. So they have to stay in the hospital. We'll put them on IV heparin initially, and then depends. If it's valvular, then we'll send them home on what? Warfarin. Now, the bridging I explained specifically under the recording. Please listen to the recording. Okay, watch it. Because you need to understand the bridging with heparin and warfarin. Why are they put on two at the same time? All right, and explain there because it's a little long explanation. And then the patient will eventually be discharged home once the bleeding time target is reached, which is usually 1.5 to 2 times the control or the normal. If it's warfarin, the INR target for a PE is usually 2 to 3. However, if the patient has had 1 PE or more before, the target becomes 3 to 4, right? Even higher, because obviously the patient has a higher risk. They had PE before, they had another one now. So we'll set the target higher. So they're higher risk for bleeding as a result. Now, massive PE, these patients are critical because they are hemodynamically unstable, meaning the clots are so big or the clots are so many that it causes acute pulmonary hypertension. The heart failed as a result. Because what is the job of the right side of the heart? Push blood where? Into the pulmonary arteries, correct? If those pulmonary arteries are blocked, what will happen to the right side? Congestion, it will fail like this. So the patient, plus what happens to forward blood flow? We need to get blood into the pulmonary arteries, right? and they need to come back via the pulmonary veins. Since they can't pass through the pulmonary arteries, so what happens to cardiac output? It drops. That's why they are hemodynamically unstable. They actually go into cardiac arrest. So we do CPR, full ACLS, bring them back, and then as far as the PE is concerned, they'll be given thrombolytics. Okay, only massive PE. Submassive PE is hardly ever given thrombolytics. It's not worth the risk. Okay, so only anticoagulants. Okay, so long story short, this is how you manage unstable PE or massive PE. So again, most of these patients go into cardiac arrest. So full ICU, okay, intubation, mechanical ventilation, and then of course we may have to give alteplase to dissolve the clot, or if they're too big, surgical embolectomy. Okay, so we literally surgically remove the clots. For patients who are not good candidates for anticoagulation, meaning too old, 80 years old, what will happen to that 80-year-old? You put them on anticoagulants. One fall, they're dead. They'll bleed to death. Okay, so some people you can't anticoagulate. What's an option? A filter. Or since as of 5 years ago, we have the Watchman now. We have the left atrial appendage closure device. Okay, you've heard of a Watchman, right? It's a patch. It's a patch they put in the left atrium. Okay. Or you can have a filter like this. It's 98% effective. Only a 2% failure rate. The other interventions here are symptomatic, meaning we put them on oxygen because it is a PE. Okay. As far as bleeding precautions, we already had the bleeding precautions under VTE listed. They have some additional here. If you compare this chart to the other one from under VTE, it's very similar. But at least this one includes prevention of another PE. Okay. Let's say, stockings, walking, don't cross your legs. Who has the habit of crossing their legs? Oh, Katri, who else? Christina. Oh, Peter. Okay. I just told you, uncross your legs.
Oh.
Still want to be a nurse, right?
Mm.
Not the patient.
Right.
Unless you want to be the patient.
It's like, that's it. That's not the- no. God.
All right. Last one. Let's go to respiratory failure.
Right. Oh, yes. Rocks scattered. These are new stuff.
Okay, these two are very short. For respiratory failure, this is a state. So there are many causes. I'll go to the causes first. Well, okay. So causes are multiple. There are cardiac causes. There are also there are pulmonary causes. There are also non-pulmonary causes. Pulmonary causes, examples are pneumonia, heart failure, pneumonia, or let's say PE, COPD. Those are your pulmonary causes. But look at the non-pulmonary causes. There are multiple. There are two forms of respiratory failure. It's either a failure of oxygenation or a failure of ventilation. Is oxygenation and ventilation the same? No. Gas exchange or oxygenation is the actual exchange of gases via diffusion, correct? At the alveolar capillary level. That's oxygenation. That's gas exchange. Ventilation is what? No, ventilation. What is ventilation? That's a ventilator, a fan. What is it doing? Okay, the act of inhalation and exhalation. That's ventilation. Okay, so it's totally separate from gas exchange. Gas exchange is at the alveolar capillary level. Ventilation is mechanical, correct? That's by your diaphragm or through a machine. So oxygenation failure includes infection like pneumonia, right? Or you drown, for instance, okay? Or let's say you inhaled toxins or you tried to kill yourself with carbon monoxide, for instance, okay? Or um, you drowned in sewer water, for instance, okay? Or you aspirated, okay, while after eating taco and too much beer. So that alfalfa, you vomited and then you were supine. Up went the tacos and then went right back into your lungs. Okay. So many ways to experience oxygenation failure. Now, ventilation failure is through the following. Let's say you overdosed on cocaine, overdose on opioids. All right. Drug overdose, head trauma. Why does head trauma lead to ventilatory failure? Brain herniation. Okay. Brain herniation leads to ventilatory failure. Infection. Sepsis, remember? Yeah, sepsis leads to acute respiratory failure. Hemorrhage, sleep apnea, or myasthenia gravis, Guillain-Barré syndrome. These are all going to affect ventilation. Okay, so anything that causes your respiratory rate to drop, your respiratory depth to drop, that's ventilatory failure type of respiratory failure. Okay, so we admitted with just respiratory failure? No, because respiratory failure is basically a complication, okay, from all of these conditions here. So if you're asked, how do you prevent respiratory failure? Which one will you pick as the people at risk? These people right here, okay, that will have either ventilatory or oxygenation failure, right? Now, here we forgot cystic fibrosis. Okay, so those are obviously a oxygenation or ventilatory. Cystic fibrosis. You know, so many mucus everywhere. Oxygenation. COPD. Actually, COPD falls under both. So COPD can be oxygenation, especially emphysema, right? Emphysema can be oxygenation failure, or chronic bronchitis can be ventilatory failure. Manifestations, okay, so there are three conditions for you to meet respiratory failure. Meaning, let's say I came in with pneumonia, right? I'm in pneumonia, I'm right here. Can't breathe, okay, I don't look good, right? I don't feel good. Then they draw ABG. The only way you can diagnose respiratory failure is with an ABG. If my ABG meets three conditions, they are a PaO2 of less than 60, a PaCO2 of over 50, and my pH is less than 7.35. What do I have? respiratory failure. You can also add a fourth one. My oxygen saturation will be below 90%. I am in respiratory failure. So my diagnosis is now what? Pneumonia with respiratory failure. Good thing about respiratory failure is the patient responds to oxygen. That's the only treatment for respiratory failure. You treat it with oxygen. Because why oxygen? Because your PaO2 is less than 60, your PaCO2 is over 50, and your pH is 7.35, less than 7.35. So you are in what condition? Respiratory acidosis. Okay. So the only treatment is oxygen. But remember, this chapter only talks about what? Respiratory failure. So what is this treating? So what is oxygen treating? Respiratory failure. Did the oxygen treat the pneumonia, cystic fibrosis, Guillain-Barré syndrome, um, what else did you say? Yeah, COPD or myasthenia gravis. Did we treat that? No. Are we clear? Okay, so what is oxygen only treating? Just the respiratory failure. And that's again the good news about the only good thing about respiratory failure is it responds to oxygen. You give them oxygen, they do better, right? Until you can treat the underlying cause. So treat the pneumonia, treat the cystic fibrosis, whatever. Okay, what's causing the oxygenation or the ventilatory failure? Are we clear? All right, now let's go to ARDS. We'll do mechanical ventilation and intubation for final exam. So last part is the ARDS.
So we need to know about mechanical ventilation.
For the final exam.
For the final.
This will probably be just 10 minutes because you already know respiratory failure. So what is ARDS? ARDS is a form of respiratory failure, meaning what is this patient's ABG? Be specific. No. So what will the ABG show? PaO2 of less than 60, PaCO2 of over 50, pH is less than. Exactly. Okay, because is this respiratory failure? Yes, this is a progressive form of respiratory failure. Now, I mentioned this thing in burns. I mentioned this thing in DIC. I mentioned this thing in septic shock. So is this a primary condition? This is a complication. Okay, so if you get COVID and you got pneumonia from COVID, you went septic, you will develop ARDS. So you'll either die from sepsis or die from this, whichever one gets you first. Okay. Now, why is this a progressive form? Because unlike respiratory failure, which responds to oxygen, ARDS does not. So what happens? How did you get ARDS? Because of acute lung injury. Now, this is a broad term. Acute lung injury, what do you think is the literal meaning? Injury to the lung, okay? So you'll think what? The pneumonia, right? Or COVID, right? Or let's say you drowned. That's acute lung injury, correct? All right. So when you say acute lung injury, there's two types though. There's direct lung injury and there's also indirect lung injury. Direct lung injury are the few things I mentioned. You drowned, you aspirated, you had sepsis from pneumonia. Okay, so these are the direct lung injury, meaning the lung itself was injured. Okay. Like the taco example I gave earlier, okay, with alcohol, beer, with taco, and then you aspirated all that, went into your lungs, or you fell into a manhole during a flood, right? You're somewhere in Queens, okay? Somebody left the manhole open, the cover was off, you fell, and it was flooding, you were picked up, you came out 3 blocks away, you came out of another uncovered a manhole over there, all right? Then you already drowned, okay? So there's some poop, mud in your lungs, okay? So that's direct lung injury, correct? There is indirect lung injury. Examples of indirect lung injury are drug ingestion overdose. What else? Major surgery, DIC, massive transfusions, bypass, indirect. Those are indirect. Here, trauma, multiple fractures, head injury. These are indirect lung injury. So what do all of these have in common? Are any of these minor conditions? Like, is it something, you'll survive? These are all serious conditions, correct? Okay. So if these are serious conditions, they lead to acute respiratory distress syndrome. What can you say is acute respiratory distress syndrome, therefore? So if we look at the pathophysiology of acute lung injury, you'll have to read the whole paragraph, but I'll just point out to inflammatory triggers, which are caused by these conditions here, trigger the release of cellular chemical mediators, causing injury to the alveolar capillary membrane, in addition to structural damage to the lungs. And because of the infiltration of these inflammatory triggers, alveoli collapse because inflammatory infiltrate. Blood, fluid, and surfactant will be leaking. Okay, so basically, what happens to the alveoli? Now, we have about 100 million alveoli, each one wrapped in a capillary network. So if this is occurring at the capillary level, meaning every capillary that wraps each of those 100 million alveoli leak fluid, blood, and surfactant, what happens to the alveoli? And what will enter the alveoli? All of these liquid here will enter the alveoli. So your lungs are wet. You're literally drowning. Okay? So how do you ventilate a wet lung? How is gas exchange possible? So that's why, unlike respiratory failure, which responds to oxygen, what is this? This does not respond to oxygen. Here, we call that refractory hypoxemia, or hypoxemia unresponsive to oxygen. Because how do you ventilate a balloon that is filled with water? Can you? No. So what else will be seen? So we take an X-ray. Patient will have progressive pulmonary edema, meaning it'll look white. What is supposed to be the appearance of the lungs on chest X-ray? Black. Here, because it's all wet, it looks white. They also describe it as ground glass appearance. Have you seen ground glass? No, when you pulverize glass, it looks white, yeah? Regardless if it's clear glass, brown glass, green glass, black glass, if you pulverize it, it looks white. That's what your chest will look like. Your lungs will look like ground glass or white out appearance. And again, don't forget the ABG result, okay, respiratory failure level. Again, the defining feature is ground glass appearance, widespread pulmonary edema, and refractory hypoxemia. So what's the only way to treat ARDS? Mechanical ventilation. We treat it with oxygen, but since the delivery is useless if it's not under pressure, meaning how can gas exchange occur without pressure? So you need a ventilator. So there's special maneuvers that will be applied. High pressures will be delivered, pushing the air out. Pushing the water out of the alveoli. So the water, the liquid, all this blood infiltrate fluid will be pushed out by the force of the mechanical ventilator, pushing it back into the alveoli. But however, once the ventilator stops pushing air, what will happen to all that water? They'll go right back into the alveoli. Why? Because the capillaries are leaking. They cannot hold the fluids. Okay, they're leaking. So the only way to make gas exchange possible is through that ventilator. Every time the ventilator pushes the air, gas exchange happens. So that occurs over 1 second, correct? So over 1 second, there is gas exchange. After that, no, water returns to the alveoli. And then next breath comes, gas exchange again, over 1 second, and then back again. But did we achieve the goal? Yes, we oxygenated the patient's blood. Okay, are we clear? So and what's what did this chapter section here address only? What did this treat? ARDS only. How did we treat it? With mechanical ventilation. What about the underlying condition? It's not mentioned here. Okay, yeah, different chapters. You still have to treat the shock, trauma, sepsis, whatever is listed here. Whatever led to the ARDS, you treat. But two most common causes of ARDS is shock and sepsis. Okay, whatever type of shock sepsis is also a form of shock, yeah? Okay. All right, that's it, guys, for exam 3. Any questions?